Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Sickle Cell Disease and Other Hemoglobinopathies, Newborn Screening and Beyond. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear later in the program. Also, the handouts, sign-in sheet, CMA claim form, and evaluations are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses, social workers, and physicians for today's program. CME credit for physicians is only available if today's program is viewed live and will not be offered for on-demand viewing. To obtain a CME transcript for viewing the live program, physicians must complete and return the CME claim form and evaluation form available with the handouts. Documents for CME credit must be submitted by April 10, 2017 to receive credit for viewing this program. Continuing education credit for nurses and social workers is approved for both live and on-demand viewing. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on March 31, 2018, and 2 years for social workers, expiring on March 31, 2019. No relevant financial relationships have been identified for CME planning members or speakers for today's program. I'm Saresha Johnson, nurse educator for the newborn screening program at the Alabama Department of Public Health. And joining me today, we have Dr. Felicia Wilson, Director of the Division of Hematology and Oncology and Associate Professor in the Department of Physician Assistant Studies at the University of South Alabama, Dr. Thomas Howard, Professor Emeritus of Pediatrics at the Division of Pediatric Hematology and Oncology at the University of Alabama at Birmingham, and Kiva Jones, Executive Director of the Mobile Chapter of the Sickle Cell Disease Association of America. Welcome, and let's begin with Dr. Wilson.
Good afternoon. My financial disclosures are listed on the slide, so you have that there. And I will discuss some of the off-label use and investigational uses for future directions in sickle cell disease. Newborn screening is a series of testing, including screening for hearing. With just 5 blood spots, we test about 30 of the 34 recommended diseases, as well as about 26 other secondary diseases. And we also do pulse oximetry screening for complex congenital heart disease. The purpose of newborn screening is to ensure early identification and follow-up of infants who are affected with certain genetic, metabolic, hormonal, or functional conditions. The key point is that these infants may appear healthy at birth, but have a medical condition that, when untreated, may lead to severe intellectual disability, developmental disabilities, as well as premature death. In Alabama, we screen about 60,000 babies each year. So why do we screen? Well, public health laws of Alabama state that each infant less than or equal to 28 days of age will be tested for inheritable diseases and conditions as designated by the State Board of Health. The State Board of Health shall put law into effect to provide for the care and treatment of these newborn infants whose tests are determined positive. So sickle cell disease is one of the things we screen for in the newborn. It is a genetic blood disorder that affects the hemoglobin protein inside of the red blood cells that carries oxygen throughout the body. Normal red blood cells are depicted in the top picture, and they are flexible and flow freely within a blood vessel delivering oxygen. They last about an average of 120 days in the bloodstream. Sickle cells, however, are rigid and tend to stick to the lining of the blood vessel, which blocks blood flow to areas of the body. They last only an average of 19 days in the bloodstream. And this abnormality is what creates the chronic anemia But we also see serious infections, severe painful episodes, strokes, damage to body organs, and early death. At the bottom of the picture, we can see where the sickle cells have clumped together and caused an occlusion, and distal to the occlusion there is no blood flow, which means those tissues don't get adequate oxygen. And we'll talk a little more about the myriad of clinical complications that result from this vaso-occlusion or blockage in blood flow. There are different types of sickle cell. They all have in common the presence of sickle hemoglobin. So we have hemoglobin SS, and people who have this form of disease inherit 2 sickle genes, one from each parent. This, by convention, is commonly called sickle cell anemia, whereas other forms we refer to as sickle cell disease. Hemoglobin SS is usually one of the most severe forms of the disease. But the sickle hemoglobin can occur in combination with other abnormal hemoglobins to create other forms of sickle cell disease. So we also have hemoglobin SC. In this form, an individual inherits one S gene from one parent and a C gene from the other parent. This is usually a milder form of sickle cell disease. There's also hemoglobin S beta thalassemia, and people who have this inherit a sickle gene from one parent and a thalassemia gene from the other parent. There are 2 types of beta thalassemia. We refer to them as beta 0, where you don't make any normal hemoglobin, and beta plus, where you make a small amount. Those with hemoglobin S beta 0 thalassemia usually have a severe form of the disease, sometimes as severe as hemoglobin SS. Usually people who have hemoglobin S beta plus thalassemia do tend to have a milder form of disease. There are also a few other rare types of sickle cell disease, including SD, SE, and SO. People who have these forms inherit one sickle gene from one parent and the other abnormal gene from the other parent. And the severity of these rarer types varies. One other form that I want to mention is called hemoglobin S, hereditary persistence of fetal hemoglobin. The fetal hemoglobin, in a mixture with the sickle, lessens the severity of the disease, and people who have hemoglobin S HPFH usually do not have sickle-related problems. Newborn screening is one of Alabama's most important and effective public health programs. Screening for sickle cell disease began in 1988. However, newborn screening in Alabama began in 1965. The historical aspect of that is in the 1970s, the average lifespan of an individual with sickle cell disease was 14 years, making it a disease of childhood. There were very few adult survivors. It was recognized as a major public health concern, so to learn more about the natural history of sickle cell disease in a prospective manner, the National Institutes of Health initiated the cooperative study of sickle cell disease in 1978. Out of that information, mortality data was generated to show that the major cause of death was sepsis due to Streptococcus pneumoniae. In an effort to address that issue, a study was also done, which was a randomized controlled clinical trial to see if prophylactic doses of penicillin would have an impact on the survival of individuals with sickle cell disease. And out of that came perhaps the first landmark study in sickle cell. Babies were randomized before 3 months of age to either receive penicillin twice a day or placebo. There was an early divergence seen in these groups. However, it was double-blinded, so neither the physicians nor the parents knew whether the child was receiving penicillin or the placebo. The NIH terminated that study by 18 months. It was terminated early, and prophylactic penicillin became the standard of care. So here you see the publication that was in New England Journal of Medicine. There was an 84% reduction in the incidence of sepsis and death due to penicillin prophylaxis. And now a disease of childhood was transformed into one where there was a 90% probability that the child would survive into adulthood. This was actually the greatest impetus for widespread implementation of newborn screening for sickle cell disease. Because of the damage to the spleen, individuals with sickle cell would have trouble managing these infections. We also know that immunizations play an important role as well. So this slide shows the legacy of excellence in sickle cell disease research, and it has greatly extended the life expectation. The first report of sickle cell disease came in 1910, and you can see that the survival rate there was less than 5%. Or 5 years. With the penicillin prophylaxis study, what you see on the graph is a rapid increase in the slope for life expectancy in years. So this was a landmark study and has really changed the landscape of sickle cell disease. This was a study published by Vachinsky and Associates in 1988 that showed that earlier diagnosis positively impacted survival. So this graph shows the green line at the top with those with SS disease who were diagnosed in the newborn period versus those who were diagnosed after that period. And you see the sharp decline in the lifespan and survival. The complications in sickle cell disease affect every organ system in the body. And so starting from head to toe, one of the most devastating complications is a stroke. About 10% of children, maybe up to 17% with sickle cell disease, have strokes. In that, about 22% additionally have what we call a silent stroke, where there are no clinical symptoms, but on MRI there is evidence of a previous stroke. In this, by early identification, we also have a method of screening called transcranial Doppler ultrasonography, where we can identify kids early before the first stroke ever presents. The sickle cells cause damage to the lining of the blood vessels, the vascular endothelium. And as the endothelium heals from that damage, scar formation occurs, which then narrows the lumen, and the passageway for blood flow is blocked. With early identification, we are able to do chronic transfusion therapy and prevent the first stroke from occurring. So with newborn screening, we're able to inform parents. The educational aspect of what we're able to do has made a significant impact. And we start screening for stroke at 2 years of age. Retinopathy is a big problem because some of the tiniest vessels in the body are located in the retina. Even though individuals with SC disease tend to have a milder form, they do have a higher incidence of this retinopathy. So again, as blood flow is blocked in the vessels of the retina, then the parts of the retina that don't get enough oxygen don't function properly, and they die out, and that can lead to vision difficulties, retinal detachment, even blindness. We generally start vision screening around school age. Coming on down the body, lung disease is an important part of management in sickle cell disease, so we can inform parents about those complications. A severe form of pneumonia called acute chest syndrome is unique to individuals with sickle cell disease. It is now the leading cause of death and the second leading cause of hospitalizations behind the pain crisis. So acute chest syndrome has the greatest predictive value for future development of sickle chronic lung disease. Pulmonary function testing can pick up early changes where we can then manage these complications before they become severe. Most children, however, are not able to effectively and reliably perform pulmonary function tests prior to the age of 7 years. We also do screening for abnormalities of the heart. Because of the chronic anemia, individuals with sickle cell do have decreased exercise tolerance. They also have cardiomegaly. And so baseline measurements of this are important because we know pulmonary hypertension is emerging as a significant problem in the adult patients. We feel that if we can detect problems early in childhood and make interventions then, we can prevent some of the major organ damage and organ failure that's manifested in adulthood. Coming on down the body, because of the rapid breakdown and increased turnover of bilirubin from the hemolysis of the sickle cells, these individuals are at risk for gallstones. The presence of gallstones is not problematic. However, when they do start to create problems, then cholecystectomy is warranted. We've talked about the prophylactic penicillin study and the importance of that and the impact it has had on survival. So the spleen in particular is an organ that is damaged by the sickle cells. What we know from the cooperative study is that by 6 months of age, 12% of individuals with sickle cell already have a defect in their splenic function so that they're not able to handle infections well. And with the more severe types of disease, by 5 years of age, the spleen is so damaged that it's not functional. And we call that functional asplenia. Another significant problem that can happen early in life, underscoring the importance of newborn screening, is a condition we call acute splenic sequestration crisis. In this episode of vaso-occlusion, for reasons we don't clearly understand, the spleen starts to trap a significant amount of the blood cells in it, which causes the spleen to rapidly enlarge. Not only is this a painful condition, but then the rest of the body in severe cases may experience shock. So this is a medical emergency warranting an immediate blood transfusion and later removal of the spleen, because we know once this complication occurs, a significant number will have another episode, which could be fatal. The liver is also affected. There can be sequestration in the liver as well. Now, the liver is not as distensible as the spleen, and so it's usually not a life-threatening emergency like splenic sequestration, but it does occur. There are other forms of hepatopathy that are affected by sickle cells, and also because of the large number of blood transfusions that are used to manage many of these complications, then hepatitis is also a consideration. When we transfuse blood, one of the other considerations for the liver is chronic iron overload. On a daily basis, we hear about the importance of this micronutrient in the diet. But in the food that we eat, we take in about 10 to 20 milligrams of iron a day. And when it reaches the small intestine, we only absorb about 1 to 2 milligrams of iron a day. But as we excrete cells of our intestine and our urine, then we may excrete about 1 to 2 milligrams of iron a day. The iron that we have that is a vital part of our blood cells is actually what carries the oxygen. So as we break down blood cells, we just recycle the iron. So the body did not physiologically have a way to get extra iron, so we don't have a physiologic way of getting rid of it. So with chronic transfusion therapy, 1 unit of blood has about 100 to 200 milligrams of iron that's added to the body for each unit of blood. For adults, a transfusion may be 2 units of blood. So in a matter of a few hours, they are getting 100 to 200 or even 400 times the amount of iron they could ever ingest in a day without a way to get rid of it from the body. That extra iron causes problems to the heart, the liver, the pancreas, which secretes insulin. So if we damage our pancreas with extra iron, then we also are at risk for development of diabetes. The glands in the body can be damaged by iron overload. So these are some of the complications we see in the liver. Cirrhosis. We also know that the iron overload also predisposes to hepatocellular carcinoma. So these are serious conditions that need monitoring and also underscore the importance of early diagnosis. In the kidney, we can see sickle-related problems. The first thing we see is perhaps an inability to concentrate the urine. When we're dehydrated, we then concentrate our urine so that we conserve water in the body. The damage from sickle cell doesn't allow individuals to do that. So dehydration is an important thing that they get from this hyposphenuria. We also see about 3% of our patients have renal failure requiring dialysis. In the extremities, we can see painful episodes. The pain crisis is actually the most common reason for emergency room visits and hospitalization, and they are experienced by most individuals with sickle cell disease. Bone infections and leg ulcers are also important considerations. So these are just some of the complications that are experienced by individuals with sickle cell. For those who may not manifest with these problems, on a daily basis, there is ongoing sickling and blockages of blood flow throughout the body that may be asymptomatic, and they show up in adulthood as organ damage and ultimately organ failure. So what we know is that when we are managing these complications in children, what we do early is important. So newborn screening, penicillin prophylaxis, educating our parents about splenic sequestration, which can be life-threatening, is vital to the survival of these children. When we're able to bring them in early, then we can teach the parents about splenic sequestration. We can teach them how to look for an enlarging spleen and get medical attention early. We're also able to talk about the other health maintenance screenings like the transcranial Doppler ultrasound for stroke, the eye examination, echocardiography, as well as pulmonary function, liver function, and renal function. Red blood cell transfusions, as I've alluded to, play a major role in the management of sickle cell disease complications. The red blood cells are what deliver oxygen, so when we have chronic anemia and we get complications on top of that, we can get significant anemias that lead to fatal complications if not treated early. Stroke prevention is one of the big areas where chronic transfusion is important. So let's just talk a minute about what transfusion is and what we mean by chronic and episodic that are shown on the slide. Normally, think of individuals who have SS of having hemoglobin levels between 6 to 8. So this is their oxygen carrying capacity. A normal adult should have a hemoglobin of at least 13.5. When we look at children, there are developmental variations for what the normal values of hemoglobin should be. But for the 6-month-old child, that child should have a hemoglobin of at least 10.5, which increases throughout life, and they reach adult values around puberty. So imagine functioning at 13.5 or even 10.5 versus a 6. And then if you have a complication and that 6 drops to 4, now we really have significant impairment of oxygen delivery. Stroke, as I mentioned, is perhaps the most devastating complication. When we have anemia, there are certain signals that are sent throughout the body to increase production of red blood cells. All of our blood cells are made on the inside of our bones in what we call bone marrow. So if the signal is sent to the bone marrow that we have anemia, we really rev up our production of blood cells in the bone marrow. We need to make a constant supply of blood cells because, remember, a red blood cell only lasts about 120 days in the circulation under normal conditions, but for the sickle cell, it's only an average of 19 days. So on a regular basis, there are red cells that are coming to the end of their lifespan and need to be replaced. So when we replace those cells with the normal bone marrow, their bone marrow is putting out lots of sickle cells. So if we transfuse them with normal blood cells up to a hemoglobin of 10, that causes the bone marrow to relax and not make sickle cells. But again, those cells don't last for a long time, so when we say chronic transfusion, it needs to be done on a monthly basis. For some kids, that may mean every 3 weeks, for some every 5 weeks. Once a child with sickle cell has had a stroke, we know that 80 to 90% of them are going to recur with another stroke within a couple of years. So once they have had a stroke, to prevent that second stroke, they go on chronic transfusion. And ultimately what we're able to do is maintain the hemoglobin around 10, which suppresses the amount of circulating sickle cells. So if we were to do the electrophoresis or the liquid chromatography that we do to look at the percent of their blood that's sickle, it might be 95 or above in the normal condition, but with chronic transfusion, keeping the hemoglobin at 10, we can decrease that value to only 30% hemoglobin S. And that's how strokes are prevented. Once a child has a stroke, they need to remain on chronic transfusion for life. With the invention of transcranial Doppler ultrasound, where we're able to detect conditions setting up for stroke, once that test turns positive, we know that a stroke will occur. We're able to start chronic transfusion at that point and prevent the first stroke from ever happening. And we've decreased the incidence of stroke by more than 90%. So that's been really a significant thing in sickle cell disease. There are individuals who have recurrent episodes of acute chest syndrome. The initial thing we do is try to put them on hydroxyurea, which we'll talk about a little bit more later on in this presentation. But those who are not helped by hydroxyurea do benefit from chronic transfusion. The ones that you see that have an asterisk, like frequent acute pain, sequestration, leg ulcers, are a little more controversial in terms of how effective they are. But those are the conditions where regular long-term transfusions are beneficial. Episodic transfusions are one that we do when an acute episode occurs where we need to improve our hemoglobin and oxygen carrying capacity. So that's the acute management of stroke, symptomatic anemia, the acute chest, as well as multi-organ failure. We also know that when individuals with sickle cell undergo anesthesia, there can be perioperative complications, and so they also need to be transfused up to a hemoglobin of 10 prior to anesthesia for surgery. So red cell transfusions are important and have been the mainstay of management of complications for sickle cell disease. In 1995, the New England Journal of Medicine showed this publication where the effect of a drug called hydroxyurea on the frequency of pain episodes was beneficial. In fact, in this study, Hydroxyurea emerged as a drug that was initially developed for a form of leukemia called chronic myelogenous leukemia. But like many drugs that are approved for one indication, we find that they are also effective in other things. Hydroxyurea is known to turn back on the production of a hemoglobin that the fetus carries, called fetal hemoglobin. And again, when you have fetal hemoglobin mixed with sickle, it reduces the complications from sickle cell anemia. So in 1998, hydroxyurea was approved as the first drug that was found to actually treat sickle cell disease and not just a complication of it. So it was approved for individuals who are 18 years of age and older. There have been many pediatric studies, and the latest being one that we call the Twitch study, where we looked at individuals who had critical transcranial Dopplers where conditions were setting up for stroke. We put them on chronic transfusion, and the TCD normalized. So since these individuals had never had a stroke, we looked at whether we could use hydroxyurea instead of transfusions at that point to continue preventing strokes. And that study was completed and successful. In fact, now the National Institutes of Health has come out to say that all babies with the severe forms of sickle cell disease who are 9 months of age should start treatment with hydroxyurea whether they have ever had a sickle complication or not. And this comes from the fact that early treatment is important to prevent the organ damage before it occurs. Because remember, at 6 months of age in the cooperative study, 12% of babies already had enough damage to their spleen so that they could not prevent the serious pneumococcal infections, and death was the result. So hydroxyurea has remained the only drug FDA approved to treat sickle cell. But in future directions, we'll talk about one of the EPIC studies that may change that paradigm for sickle cell anemia. This slide looks at what happens in an individual with sickle cell disease before, during, and after hydroxyurea therapy. So before therapy with hydroxyurea, we again see that the chronic anemia has sent signals back to the bone marrow to rev up production of the cells. So not only does the bone marrow rev up production of the red blood cells, which are still only going to last an average of 19 days, so it never corrects the problem with sickle cell, but it also revs up production of white blood cells and platelets. So typically when we look at blood counts of individuals with sickle cell, the red blood cell count is low, but the white blood cell and the platelet count is high. We know that the lining of the blood vessel creates a problem when the sickle cells stick to it. It also upregulates that lining to attract platelets and white blood cells. So really all of the blood cells participate in this process of vaso-occlusion and blocking blood flow. So in the bone marrow before therapy, we see how cellular the bone marrow is, but during therapy with hydroxyurea, we also see that there's reduced cellularity, so we don't make as many white cells or platelets, and we also see an increase of blood cells, red blood cells that carry fetal hemoglobin. If we look at what happens in the blood before hydroxyurea therapy, we see the myriad of cells there that contribute to blockages in blood flow. And again, that decrease in cellularity during therapy with hydroxyurea. And then the vasculature, the vascular endothelium functions better. There's a reduced adherence of sickle cells to the vascular endothelium, which is what initiates the process of vaso-occlusion. So these are the mechanisms by which hydroxyurea works to treat sickle cell disease. Another treatment that is not so widely available is stem cell transplantation. This was a study published in Blood in 2000 by Mark Walters and Associates that looked at the outcome after bone marrow transplantation for 50 children with advanced symptomatic sickle cell disease. Now, so far we've talked about blood transfusions, where we only have a few blood types that we all commonly share throughout the world. So everybody is either type A, type B, type AB, or O. And then you're Rh negative or positive. So with bone marrow transplantation, we have to look at your tissue type, which is referred to as an HLA type. So first of all, it's not widely available because of the lack of donors that are HLA type to your tissue. When there is a mismatch in HLA type, then the donor cells can attack the recipient, and we call that graft versus host, which can be a fatal condition. But also, the recipient can attack the donor cells, leading to rejection of that graft. And so what we see here with the transplant of the first 50 children with sickle cell disease is what we're really talking about is the stem cell, the bone marrow stem cell that makes new red blood cells, white blood cells, and platelets. So that is what has the genetic code to make these new cells. And every time an individual with sickle cell has a stem cell that makes a new blood cell, it only has the genetic code to make the sickle cell or the sickle hemoglobin in combination with whatever abnormal hemoglobin they inherit. So if we were able to wipe out their bone marrow stem cells and then replace those stem cells with normal stem cells, or even stem cells that only make trait cells, then we could cure them of sickle cell disease. And those stem cells are infused into the patient just like a blood transfusion would be, except they go into the bone marrow. So first there has to be a suitable donor, and second of all, to get rid of the stem cells in someone's bone marrow, it requires high-dose chemotherapy and or radiation. So there can be immediate complications just from the technique of transplant itself. And what we see here is that survival in transplant is about 94%, which means for the other 6%, they didn't survive the early phase of the transplant. So it's not an easy decision even for the person in need of transplant, because they do face the 6% mortality rate, and we don't have good prognostic indications for how long they may live or what sickle complications they may encounter. But it looks like about 94% of patients do survive the transplant. About 84% had an event-free survival, which meant that they were cured of their sickle cell. But for 10%, it means that they rejected the stem cells that were transplanted, and they either were not able to make any new red cells, or they rejected it and some of their own stem cells regenerated, but they still had sickle cell disease, as well as some of the long-term complications of the chemotherapy and or radiation. So for this reason, bone marrow transplant is reserved for the sickest patients who've had some of the more life-threatening complications. But as we learn more about transplantation in sickle cell, and we're able to use umbilical cord blood, hematopoietic stem cells, and we also know that maybe we can use lower doses of chemotherapy and not involve radiation, transplants are becoming safer. But still not widely available. It is, however, a cure for sickle cell disease. So having talked about sickle cell, let's focus back on newborn screening and what results the lab does report. So this slide is inclusive of all of the different sickle cell diseases as well as traits that are reported. So what you'll also notice is you see things like FF, where fetal only, or you see BARTs. So major impetus for starting screening of hemoglobinopathy in newborns was sickle cell disease. But as a result of that, we're also able to diagnose individuals with other forms of hemoglobinopathy like thalassemia major, or hemoglobin E disease, or hemoglobin C disease, as well as those that carry traits. And in the trait condition, typically those patients are not at risk for symptoms of the disease. However, we're finding out more and more about sickle cell trait and some of the sickle-related complications that these individuals can have in extreme conditions. So here you see the various hemoglobinopathies and traits that are reported. So let's talk about which ones are tracked by the newborn screening follow-up staff. Well, hemoglobin SS, SC, and S-beta thalassemia are the ones that are followed up by the staff, and you see the traits listed, C trait and S trait, that are also followed up and referred to our community-based sickle cell organizations. We see on the other side of the screen those that are not followed up, and we've had conversation about those and whether we should or not. For instance, fetal only can mean that a baby's testing was done when they were extremely premature and we were not able to yet see the adult hemoglobins emerge. But we also know that FF can be diagnostic of thalassemia major. Now, so far we've concentrated on sickle cell disease where the hemoglobin protein is abnormal, and we call those qualitative hemoglobinopathies because the quality of the protein is abnormal. We make large amounts of it, but the function of it is not good. In the thalassemias, what we see is that the protein we make is normal. We just can't make enough of it. So these individuals have very low hemoglobins early in life and depend on transfusion early and throughout life. The scheme here shows the follow-up that's done. So notification of a presumptive positive comes from the lab. The newborn screening staff then calls the doctor of record to report the results and make sure that that baby is their patient. They also get a fax number and fax a letter to the physician. They do recommend consultation with a hematologist. They also send the result to a pediatric hematologist, and they include an act sheet which was designed by the American College of Medical Genetics to show what needs to be done. This is just a sample of the letter that is sent out when a positive is identified. This is the act sheet. And then within 1 month, we want to confirm the diagnosis. We also want to confirm the specialty appointment so that a pediatric hematologist will then work in conjunction with the primary care provider to provide the necessary care. In 2016, this is a list of confirmed primary disorders from the newborn screen, and we see here the cases of sickle cell disease. Also, hearing loss is reported in increased amounts, cystic fibrosis, as well as congenital hypothyroidism. There are several nodes of care throughout the state. The University of South Alabama, the University of Alabama in Birmingham are representatives on the Newborn Screening Advisory Committee. But we also have 7 community-based organizations. We have 6 federally qualified health centers, as well as a number of other clinics and primary care providers that participate in the care of these individuals. You can see the numbers that are listed there from the counties. There are over 3,000 individuals with sickle cell disease estimated in Alabama currently, but we're talking about better means of follow-up throughout the adult population to identify them. The National Institutes of Health has also published evidence-based management of sickle cell disease that is available online to help learn about that. And in summary for that, these are the key trials that correlate with greatly improved survival, from the discoveries of 1910 to prophylactic penicillin, where the NIH recommended screening, blood transfusions, and hydroxyurea. So I want to take just a couple of minutes to talk about future direction. So in the sickle cell disease, the sickle cell adheres to the lining of the blood vessel, and then it activates the blood vessel to attract platelets as well as white blood cells, and this is what creates the vascular occlusion. This is mediated by P-selectin, so that's what causes the sickle cells to stick and roll. It causes white blood cells to stick, and it also causes platelets to stick to these cells, leading to vascular obstruction, tissue ischemia, and the pain episodes. A new drug called crizanlizumab has been shown to block the action of P-selectin. So this, I think, is an epic study. The SUSTAIN study was a year-long trial using crizanlizumab, which is a humanized monoclonal antibody to P-selectin. And in this study, patients were randomized to receive high-dose, low-dose crizanlizumab versus placebo, and it had a 45% lower rate of pain episodes than placebo. So we're hoping to get FDA approval of only the second drug that would be approved in nearly 20 years for management of sickle cell disease. It was well tolerated, with arthralgia, diarrhea, and pruritus being some of the more common complications. This slide may be difficult to see, but it just shows that all forms of sickle cell disease were included in the study, and about 65 patients in each group with high, low, and placebo. This shows the time to the first pain crisis once they started the drug. That was also significantly reduced in those with high-dose crizanlizumab. This was the time to the second pain crisis, also significant. So in conclusion, crizanlizumab therapy resulted in a significantly lower rate of sickle cell-related pain crisis than placebo, and was associated with a low incidence of adverse events. So we are waiting to hear from the FDA whether more studies are needed or whether it will be approved for those 16 years of age and older. And with that approval, we would be looking to do the clinical trials in the younger population. And one other study that was published in New England Journal of Medicine just this month was gene therapy in a patient with sickle cell disease. So this just lets you know that there is ongoing research where a lentiviral vector was used. The bone marrow cells were harvested from an individual with sickle cell disease. Those were selected out for those that would make new blood cells. The new gene, the correct gene, was instituted. The cells were grown ex vivo, and then the patient was conditioned to wipe out the rest of their stem cells, and the new cells were included. So the first patient that was reported has really been followed for about 15 months now. So the long-term follow-up is not available, but until we are able to get new drugs and therapies instituted for sickle cell disease, newborn screening will continue to play a major role in early identification, early treatment, and education, which has been shown to significantly impact their survival. So I think now is a good time for us to take about a 10-minute break, and we'll rejoin you with Dr. Tom Howard from UAB. Okay. Thank you.
Welcome back to our program, Sickle Cell Disease and Other Hemoglobinopathies, Newborn Screening and Beyond. We're going to pick up now with Dr. Thomas Howard. Dr. Howard.
Thank you very much. My job is to go beyond. We've been talking about newborns and children in the first 9 to 12 years of life. and my job is to talk with you about the impact of sickle cell disease and, if we have opportunity and time, trait in adolescents and young adults. Sometimes I may say AYA, adolescents and young adults, as a shortened form of referring to these, because adolescents and young adults is quite a mouthful to say. So let's begin. My objectives are to review some of the major morbidity-causing sickle cell disease complications and unique presentations and therapeutic responses in adolescents and young adults. Particularly, I'm going to focus on some of the aspects of vaso-occlusive crisis, painful vaso-occlusive crisis, the fact that there's chronic pain in sickle cell disease, and then silent cerebral infarcts, which Dr. Wilson mentioned earlier as a central nervous system consequence. I will also review the evolution across time in age of one major cause of sickle cell disease mortality, that being renal disease. I will review aspects of sickle cell disease that affect the reproductive health of patients, discuss barriers and benefits to pediatric to adult medicine care transition, and, if time allows, discuss some of the medically significant features of sickle cell trait. You've already heard that the sickle cell disorders are a heterogeneous group of disorders or diseases inherited when a hemoglobin S gene combines with another hemoglobin S, another hemoglobin gene, or another thalassemia gene. Shown here are the types of diseases we speak about: SS disease, S beta 0 thalassemia SC, and S beta plus. In general, the severity of the diseases vary with the amount of sickle hemoglobin, with the exception possibly of sickle with the hereditary persistence of fetal hemoglobin, which has very few, if any, manifestations. Dr. Wilson has focused on the improvement in the life expectancy of persons with sickle cell disease, and I will continue to refer back to this because that's what has made the importance of care for adolescents and young adults so very important. Considering then this same graph from the discovery in 1910, the rapid improvements over the last 30 years. But most of those improvements really show up in the lower right-hand graph here. The lower right-hand graph reports the fraction of patients surviving by age of years in follow-up from studies that date back from the worst one shown in red in about 1970 from Jamaica until some of the more recent ones shown in purple. Overall saying with all sickle cell disorders, something in the order of 93% of patients will reach their 20th birthday. Therefore, paying attention to what is necessary for persons who are adolescents and young adults are critically important. Already you've heard of the pathophysiology of sickle cell disease, wherein a single gene defect causes an oxygen sensitivity in the cell that makes it assume a sickled shape and block blood vessels. You've also heard that those blocked blood vessels deny blood flow to any organ in the body, and the tissue beyond that blockage dies and it heals with a scar. Accumulating over a lifetime, one gets scarring of lung, kidney, heart, brain, and ultimately the sum of all those lead to early death. Now, even in the second decade of life, people begin to have significant consequences of those repeated episodes of vaso-occlusion. In this slide, I've tried to prepare for you some of the areas where we associate vaso-occlusion with particular outcomes. So, for example, if we take bone marrow, when the blood flow in the bone marrow is blocked, we get bone marrow infarction. That means that the cells of the bone marrow acutely, and that's shown in red, acutely, the acute consequence, the bone marrow swells. The bone marrow swelling causes pain and inflammation. We see this as painful vaso-occlusive crises or dactylitis in children. Now, if we have enough of those repetitive enough in one bony area, for example, the head of the femur, then we will get a vascular necrosis, a situation in which actually not only is the bone marrow infarcted, but the bone itself becomes abnormal and irregular. The smooth head of the femur becomes raggedy, and that creates a chronic pain syndrome due to an arthritis-like condition that does not occur in acute episodic fashion, but is an everyday event. Similarly, you can say repeated acute chest syndrome leads to chest pain and pneumonia, and the long-term consequences, pulmonary hypertension and pulmonary fibrosis, for example. And so you can read the rest of the complications. We'll talk a little about renal disease. The sum of all these events occurring, especially in the lungs, the brain, the kidney, and the heart, is what limits the lifespan of older patients with sickle cell disease. Let's talk for a second about unique aspects of pain, both chronic and acute, in AYA individuals. This is from Ora Platt's, this slide is from Ora Platt's paper in the New England Journal of Medicine from the Comprehensive Study of Sickle Cell Disease, which tried to look at each of the sickle cell disorders and ask how often do people have pain crises that take them to the hospital or the emergency room. And we can see that the largest number of people who have a very significant number of the pain crises are persons who have S-beta 0 thalassemia and hemoglobin SS disease, the one on the left and the one on the far right. We can also see that surprisingly her findings showed that at least amongst the SS patients, 38% of patients had no painful crises that presented to emergency rooms. So not everybody has pain. Some of those with the most anemia do not have pain, but they have many of the other complications such as strokes, priapism, or repeated chest problems. Overall, about 9 or 10% of the patients represent the ones who are admitted to the hospital 3, 4, 5, and 6 and greater times per year. So that's one way of measuring pain rate. How many times per year are you in the hospital? Now, how does that function work as a function of age? How does that work as a function of age? And that's shown in this graph from the same paper. The pain rate, which is the number of hospitalizations for the average patient per year, is in the first 9 months of life only about 0.4, whereas for the whole group it was about 0.8. But if you move into the adolescent, the 10 to 19-year-old and the 20 to 29-year-old, that pain rate is double or even triple that of the person 0 to 9. So age makes a difference in terms of the activity of sickle cell disease. We're not entirely sure why. One simple explanation would say that going through puberty changes the vascular endothelium and the chance that blood vessel walls become sticky. But we're not certain of why that happens. Another explanation would be at age between 10 and 19 years of age, we turn over to our children the ability to decide when they have pain and when they do not have pain. And just like all of us, that's a learning curve. And it takes a while to figure out what's significant. Another important thing with the persons with sickle cell disease is many of them are learned because sickle cell pain is such an important part of sickle cell disease. They've learned to interpret all pains as sickle cell pain. And yet, they're going to get the same flu that you and I get, and their muscles are going to ache, and that's not necessarily a sickle cell cause. So it's a complicated thing to interpret, but it's very clear that it's about double or triple the rate as you enter the second decade of life, pain rate. This is a terrible graph. It didn't reproduce very well. But what it's going to show, what it's trying to show is if you take into consideration, what's missing is the numbers at the bottom, but if you take into consideration home pain episodes, because all persons with sickle cell disease do not come to the hospital with them. Many of them management home. In fact, that 10% of patients actually probably have in the order of 24 pain episodes per year, not that 3, 6 that we were talking about, 10%. That 10% may have as many as 24 or 25 per year, which means that possibly, particularly for the older teen patient, half of the time they're having some significant problems. Now, I mentioned earlier that an acute event like vaso-occlusion leads to a more chronic event like avascular necrosis, a major cause of chronic pain, which can often follow multiple small or single large bone marrow infarction events. This is also known as vaso-occlusive crisis. Some of these vascular events lead to a head of the femur which is non-functional, but it also can affect other bones that give you a history of chronic pain. And those include the scapula, the clavicle, particularly as right here when it touches your shoulder blade, the head of your humerus right here, the heel. The heel bone can be infarcted. It can be exquisitely painful. And then the distal part of the knee. Whenever people have these kinds of things chronically affected and the bone structure is altered, they may have chronic pain like in anybody who has a chronic arthritis. Okay, so what about the treatment of what is unique about the treatment of chronic pain and acute pain in persons who are adolescents and young adults, particularly as refers to advanced therapies like hydroxyurea and bone marrow transplant? I'm not going to spend a lot of time on this, but I just want to point out a few unique aspects of them, okay? Now, this is simply that same graph that shows the pain rate as a function of age on the top. Now, on the bottom shows a very interesting set of studies. The red bar to the left is the report from the baby hug study, which was the treatment of babies starting at about 9 months of age through about 2 to 3 years of age. And what we saw is that hydroxyurea in that age group, 0 to 5 years, decreased the number of vaso-occlusive crises and chest syndrome in patients with sickle cell disease of that age by 90% plus. The same thing was observed in people 5 to 10 years of age. The Hughes-Soft study showed that there was about an 85 to 90% reduction in the number of vaso-occlusive crises. That stands in contrast to the next group, which is 20 to 29 years old, and actually it was 18 to 29 or 30 years old. And that was the multi-center trial, multi-center study of hydroxyurea, which reported only a 50% reduction in painful vaso-occlusive crises. Something happens during adolescence. We don't know whether that something is, as I mentioned earlier, a change in the lining of the blood vessel itself, that cells are more sticky, that goes along with puberty, or whether it represents a change, for example, in the number of cells that can make fetal hemoglobin, because we know hydroxyurea makes you make fetal hemoglobin, or the amount that any one cell can make, or that same more practical thing, which is people have a difficult time whenever they become young adults, adolescents and young adults, in interpreting their own pain. And they have to learn. But it's an interesting observation. I have no explanation, but there's a difference. It has importance in using hydroxyurea for therapy of children that you start treating at a very, very young age and they grow up with the hydroxyurea and with the disease. Because when they get to be adolescents, many of them haven't had very much pain. And suddenly, because they go through puberty, and whatever it is that happens at that point in time, now they begin to have pain. They conclude, as you and I would, this medicine isn't working anymore. Very difficult problem at adolescents and young adults is to convince them to continue taking the medicine. And we've tried different kinds of approaches. One is to say, okay, let's take you off altogether. And they can see that they have an increased risk, and a 50% reduction is a lot better than every pain crisis that you normally have. Does that make sense? I think that does. I'm going to say a few words about hematopoietic stem cell transplantation, which is also known as stem cell transplantation or bone marrow transplantation. Dr. Wilson has covered that pretty well. There's just a few details that I may add. But one of the reasons I put it in here is because I experience at our institution, we've done probably about 20 bone marrow transplants that are curative for persons with sickle cell disease. But almost always, most of those patients, with the exception of 2, were teenagers before they could decide to commit to a bone marrow transplant. Now, why would that be? And that's a unique aspect of marrow transplant. And why would that be? One is that many times families don't have enough experience with the patient's disease yet when they're young to be convinced that taking the risk of a bone marrow transplant would be okay. A second is that they're convinced, but they want the child to also commit because, as Dr. Wilson said, there's a risk of death associated with the preparative portions of and the managing of the myeloablation and the using chemotherapy and radiation in persons with bone marrow transplant. And I find it very interesting that most of the patients that we've been able to transplant have been young adults or adolescents. Probably on average our age is about 16 for transplant. And mostly families want that child to participate in that decision. A few things about transplant. Hematopoietic stem cell is the cell that we transplant, People who make hemoglobin A and have normal, these are the cells that make your red blood cells, your white blood cells, your infection-fighting cells, and also those that make up your immune system. As Dr. Wilson said, we're trying to match people's HLA immune system. We may even change your blood type during the course of a bone marrow transplant, but we want your immune system to be perfectly matched. And the key thing about sickle hematopoietic stem cells is that the sickle hematopoietic stem cell, that cell can only, when it becomes a red cell, only make sickle hemoglobin. There are several sources of hematopoietic stem cells. We can get it by putting a needle directly in the bone, shown in the upper left, and aspirating the bone marrow out. We can get it by getting cord blood from an umbilical cord. Or we can do it, and we can do it from either related donors, shown in the top right, that means a sibling, a full brother or sister, or unrelated donors, people who are not at all related but just by chance happen to match you in your HLA or your immune typing. Those are the sources of hematopoietic stem cells. The best outcomes occur with matched, related marrow donor transplantations. Okay, so what's the transplant look like? Well, you have to have a hematopoietic stem cell source, shown there in the center, and then with the big arrow going down to the lower right, you have to take the individual, and you get the individual to accept those hematopoietic stem cells from the other person. In this instance, a related or an unrelated donor might be possible. As Dr. Wilson said, we first have to get rid of your own stem cells by myeloablation. That means destroying the bone marrow. We do that with high-dose chemotherapy and sometimes radiation. There's a period of aplasia. That means you don't have any white blood cells, platelets, or red blood cells, and you're totally transfusion dependent for those for a period of usually around 21, but it can be as long as 40 days. And then once we hang a bag of blood, that's the red thing in the center, of A-containing hematopoietic stem cells. Those cells circulate in the blood, then home to the bone marrow, reconstitute the bone marrow, and the person now has hemoglobin A producing cells, but a different immune system than before. Who should be considered for hematopoietic stem cells as transplant? As Dr. Wilson said, those people who are more severe generally. But that includes the possibility that if chronic pain is so severe that it's going to limit your ability as a young person to see a future that makes any sense, then bone marrow transplant might be for you. But nobody who takes on bone marrow transplant can do it without a risk. And there's a risk of having to have support for your whole body for 21 to 40 days by transfusion. Some people can die of infection. Some people can die of bleeding, but it does happen. What are the benefits? Well, the cure rates, and this is an old slide, and I think more recent data would say more like 91, 92% cure rates, with about 3% graft versus host disease chronic, about 3% rejection, and about 3% death due to the effort to try to get through the transplant. If chronically transfused, they don't have to be transfused anymore. Exact cure rates for non-related hematopoietic stem cell are not actually out there that readily, and people are trying non-myeloablative and are also trying to transplant parents into child, because not everybody, only about 1 in 9 persons who have sickle cell disease really does have a HLA identical, immune matched full sibling to be a donor. Those are the ones with the best outcome. The risk of hematopoietic stem cell transplant are short-term infection, bleeding, graft versus host disease, donor rejection, and the 8% mortality is an old number. It's more like 3 to 5 at this point in time. Long-term, there are problems with late graft versus host, short stature, sterility, and an unknown risk of leukemia or late cancers. Okay. Since we're talking about adolescence, and since in adolescence we obtain the ability to reproduce, then reproductive health is very important. And here are a couple of 3 unique aspects of sickle cell disease that occur in those persons of that age group. 1, priapism, 2, pregnancy, and 3, azoospermia, or low sperm count, in association with the receipt of hydroxyurea. Let's talk a little bit about priapism. There's a lot of writing up here, and I'm going to read along with you and try to fill in the blanks. Priapism is only occurs in males and is the spontaneous occurrence of an unwanted, painful penile erection of prolonged duration. Sickle cell disease is the most frequent cause of priapism in man. In many studies ranging from 30 to 45% of sickle cell disease males will have an episode of priapism. Adolescent males, as they're learning of priapism, and since we teach them about priapism, have a great deal of fear, I think, about this because they have to learn to distinguish it from a normal erection. And sometimes early on, that's a little complicated. Sickle cell disease males are particularly predisposed to priapism because they are chronically nitric oxide deficient, and I'll try to explain that in subsequent slides. Repeated episodes of priapism, the so-called stuttering priapism or recurrent ischemic priapism, can lead to very severe consequences for these young males. They may have erectile dysfunction, not the kind of dysfunction where an erection cannot be maintained, but the kind in which the penis never goes down to normal size. That can lead to penile fibrosis. The penis itself becomes large and woody almost, and painful all the time, and sex is painful. And it can create then chronic pain and obviously then severe, significant psychological and social dysfunction. This is a big problem and one that's not talked about very much because guys don't want to talk about it, and oftentimes they'll conceal it or not think it's such a big deal. But over the long term, if it's a repetitive event, it's a very big problem for young males. Paradoxically, we have learned that you can prevent priapism by giving patients with sickle cell Viagra. Now that seems totally illogical, but you have to understand that the person with sickle cell disease, because of their physiology, their physiology is 180 degrees opposite of normal physiology, because normally we have an erection by virtue of the fact that we can generate nitric oxide. Persons with sickle cell disease have zero possibility of generating nitric oxide. So if you will stick with me, I will try to review some pictures and describe a little bit of this. It's a little bit scientific, but it's a lot of fun to think about, okay? All right, on the right-hand side, we see a flaccid penis. The penis is flaccid because the artery that feeds the penis is contracted, and not a large amount of flow is going to the penis. Upon appropriate stimulation, then what happens is the blood flow is increased to this penis because the artery feeding the penis is dilated, and suddenly there's a large flow of blood into the penis, and then like in the lower right-hand corner, the penis then rises, and it becomes congested with blood that flows in faster than it can flow out. That is all controlled by that great big pink blob on the left-hand side, which is a smooth muscle cell. A smooth muscle cell works in the following way. First of all, over to the left, you'll see these little purple things that come out, and that's nitric oxide. When you stimulate a nerve, you generate nitric oxide. Nitric oxide then operates on something called guanylyl cyclase to produce something called cyclic GMP. Cyclic GMP, when there's a surge of it, activates a kinase that turns on that muscle cell that makes that affects that muscle cell in such a way that it relaxes. And that smooth muscle cell is the one that is contracting the artery. Therefore, when it relaxes and dilates, the blood flow surges into the penis and there's an erection. Now, how much cyclic GMP there is depends not only upon how much nitric oxide there is, but also how much phosphodiesterase. That can be seen, I think it's circled in this right here. Okay, that's the lowest red circle. Now that phosphodiesterase breaks down the cyclic GMP. So nitric oxide raises it, phosphodiesterase lowers it, and the way Viagra works is it inhibits the phosphodiesterase, so it's raised all the time, and therefore relaxes the muscle and allows flow of blood into the penis. That's normal physiology. What does abnormal physiology in sickle cell, and why is it abnormal? Well, once again, I have a very complex slide here, but it's very simple what I need you to focus on. In the top left of this slide is a red blood cell. Inside that red blood cell are these little reddish-brown pellets. That's the hemoglobin. This red blood cell, Dr. Wilson has told us, does not have a normal lifespan, so it breaks open. When it breaks open, that hemoglobin spills out into the blood. And you can see those hemoglobin molecules, those little reddish-brown ones, dribbling down to where there's two of them hooked together, and right there's nitric oxide. That nitric oxide reacts with the heme and the iron in hemoglobin, and the nitric oxide is destroyed into nitrate in a person with sickle cell disease because they have free hemoglobin in their blood. They have zero nitric oxide. That sets them up so that they turn off totally their phosphodiesterase, and any little surge of cyclic GMP makes them have an erection. Any little surge. And therefore they have a pro-erectile state in the baseline. Now, it turns out that when you take Viagra, you can't treat an episode of priapism, but you can prevent episodes of priapism. And when you give them Viagra, or a drug like Cialis, the drug like Viagra, then what you do is you raise the phosphodiesterase, you induce some phosphodiesterase, and so you're able to prevent some of these erections. Okay, what of pregnancy in sickle cell disease? Normally we don't think of pregnancy as a complication, and it's not a complication here either. In the days when only about 60% of the patients lived to be 20 years of age, we rarely saw women having kids. And now probably in our population of about 1,000 total patients, I would say 100 of the families in that population have one or another parent who has sickle cell disease, or close to it. Certainly 80 is right. Pregnancy can be a problem during sickle cell disease, not because you die of pregnancy mortality, but because you have sickle cell problems during the time that you're pregnant. The mortality rate associated with sickle cell disease is something in the order of, in pregnancy, is something in the order of 5 to 10 times greater than in the normal population. These people also produce children that are a little less healthy. There's an increased rate of spontaneous abortion, 36%, as opposed to about 10% in normal persons. There's an increased rate in retained placenta after delivery. There are fewer live-born infants born of persons with sickle cell disease in pregnancy. Greater proportion of those children have prematurity. A lower mean gestational age at delivery, those go together. Lower birth weight, about 41.7% of these babies are less than 2,500 grams. And the rate of stillbirths is almost tenfold in persons with sickle cell disease as opposed to normal persons. Now that's as long as you don't transfuse the people during transfusion, during pregnancy. If you start transfusing about monthly at about before the second trimester, then these outcomes are much better altered. And I want to emphasize, it's not necessarily the complications of pregnancy that increases the mortality. It's the complications of sickle cell disease visited upon the pregnancy. And what the monthly transfusions, as Dr. Wilson said, is they're avoiding those complications. Okay? So that's pregnancy and sickle cell disease. I think we're doing okay with time. All right. Now, there's also some important reproductive consequences concerning hydroxyurea that are unique to this adolescent and young adult group. One is everybody gets the non-reproductive kinds of consequences, and everybody takes that risk. It lowers white blood count, platelet and red cell counts. You can get an eczema-like rash in a rare instance of about 1 in 100, mild nausea, minimal mild hair loss, skin and more commonly nail darkening, and an unlikely but unknown risk of cancer and blood disorders. The reproductive are two in nature. One is in the early trials of hydroxyurea in use in animal studies. High doses of hydroxyurea cause fetal malformation. So there was concern during the multicenter trial of hydroxyurea that pregnancy could lead to a malformed fetus if people were taking hydroxyurea. In fact, they did not observe that. I think there were about 4 or somewhere between 4 and 6 live-born infants during the time of the multicenter trial of hydroxyurea, and none of those children were malformed. But because of the animal studies, we use it as a standard, and many people do, to put women on birth control pills to avoid pregnancy, and to counsel them that if they'd like to have a child, stop the hydroxyurea, have the child, and then come back to the hydroxyurea. That's one of the problems for females, and the problem for pubescent males is that recently it's been recognized that men who take hydroxyurea, the sperm count is decreased. Now that does not change your sexual function whatsoever. A person is fully able to have an erection, fully able to ejaculate, fully able to have a satisfactory sex life. It just means you may not be as fertile. You may not be as easy to father a child. In all instances to date that we know of, whenever we cease taking the hydroxyurea, the sperm count returns. And so the counsel there is, if you would like to father a child, then hold the hydroxyurea, allow the sperm count to recover, and then restart the hydroxyurea. Get the benefits of both fatherhood and hydroxyurea. Kidney disease in adolescents and adults. This is a key cause of mortality in adults with sickle cell disease. One of my colleagues, Jeff Liebensberger, is particularly interested in and is focusing on this in his research. In adolescents and adults, it's important to talk about because it kills adults and might account for as many as 25 to 50% of the adult mortality. For adolescents, it shows its first signs that we can easily measure, but there are signs there even that would signal potential of kidney failure even as early as 2 years of age. And I'll try to review those for you. One of the interesting observations is we look at this graph that Dr. Wilson and I both showed you about how much the life expectancy is improving, but those improvements in life expectancy of that curve all came about because of the effect of persons under 19 years of age. So if you look at the broken line here at the bottom, that's the plot of the mortality rate per 100,000 African Americans, okay? And it shows a decrease in those who are under 19 years of age. But you can see there's even a slight increase in that for those greater than 19 years of age. So the improvements have not been improvements in adult outcomes yet. Now, with the advent of hydroxyurea, and as with the people who have started on hydroxyurea move through a lifetime of being on hydroxyurea, we may see the adult mortality go down, and the problem of renal disease, chest disease, all causes go down. But we have not yet reached that point. So we only can look to see better things happening with the sickle cell survival curve. What does the kidney look like in patients who have sickle cell disease? Well, on the right-hand side, there's this blown-up picture, and the left of it is a normal kidney, and the right of it is a kidney of a person with sickle cell disease. And the key features are the kidney is small, and it is scarred down. If you look, and those are the little inset square pictures there, on the left-hand side show all the functional units of those kidneys. So on the left, you can see very healthy-looking glomeruli. Those are those little round-looking things that look a little lacy. And on the right, you see these dark blue, really complicated small things. Those are glomeruli, and that process is called glomerulosclerosis. It is a pathological process that's very similar to what we see in the kidneys of persons with diabetes, for example, chronic diabetes. Once you get glomerulosclerosis, you increase your BN and your creatinine, gross albuminuria. That means the kind of albumin you can recognize with a standard dipstick in the lab begins to appear, and then hypertension, and many of these people end up on dialysis. And it accounts for a very significant portion, at least 25% of the deaths of persons with sickle cell disease is chronic renal failure. Ignore the slide on the, ignore the left-hand picture here. It's going to be very difficult for me to explain. The right-hand picture is a plot by age of what is called the glomerular filtration rate. And it shows evidence of something called hyperfiltration. The glomerular filtration rate is the amount of blood that is cleared of solutes per minute. It's measured in mLs per minute. Okay? Normally, a GFR is probably 110, 125. As you can see, whenever the GFRs are directly measured in people with sickle cell disease, at least in the age groups of 4, well actually even in the baseline age group at 1 to 3, the glomerular filtration rate is 150 on average, elevated. In other words, they're hyperfiltering. They're filtering more solute from the blood than you and I do. They're hyperfiltering. And that maintains until about the mid-second decade of life in adolescence. And then it begins to drop. And for a significant number of people, it keeps dropping. This is some data from the baby hug study, which was treating babies starting at about 9 months of age and did GFRs. And even at 9 months of age, and certainly at 2 years of age, we can see a measurable abnormally high glomerular filtration rate. So the sequence of events that ends up in renal disease starts with hyperfiltration. And the picture looks a lot like this. Now my picture shrunk, but the thing at the bottom that says prevalence of microalbuminuria didn't shrink. But those are supposed to be lined up, and I'll explain to you how to line those up. But what I'm showing you is glomerular filtration rate slipping from 4 or 6 years of age down to 22 years of age. And if I were able to put that 5% of people having microalbuminuria, now this is albumin that is undetectable by the dipstick test, but detectable by a special test that measures the amount of protein in the urine relative to the amount of creatinine. And that 5%, 0 to 10 years of age, we rarely see people who have microalbuminuria. But at about 13, 14, we begin to have about 5%, and then that number grows to about 25% by age 22. So the sequence of events is hyperfiltration, microalbuminuria, and then progressive lowering of GFR, and now injury to the kidney with chronic kidney disease. Now, we don't know which people are the ones who will become the persons who have chronic kidney disease. We don't know whether it's like this, the ones who are the most hyperfilterers become the 54% who will develop chronic kidney disease, or whether it's the ones who start out normally and then go up and then come back down. We're not certain of that. But we know that these things become operant during adolescence and young adults, and this is an area that we have to focus on treating effectively. There have been many studies that have documented that in that 10 to 20 year age group, these are some of the range of results that people have. This is the percentage of people having. One comment on central nervous system injury in sickle cell disease in adolescents and young adults. Could it be that this is a cause of poor academic performance in children and a cause of poor job performance in young adults with sickle cell disease? Now, we have lots of young people who are going on and having great success as persons with sickle cell. We have a couple of doctors who have sickle cell disease that we've treated over the years. We have a bunch of nurses, a bunch of people going on to nursing school who have been successful. So not everybody is affected with the kinds of problems that I'm going to raise to you, which is the progression of silent cerebral infarcts. If you remember, silent cerebral infarcts are not infarctive strokes. That's when you have a big blood vessel blocked in your head and you have a lot of injury to your brain, and you may have paralysis, seizures, overt stroke. That can cause because of a blockage, and most of those, about 12% of people by 20 years of age who have sickle cell disease will have those. And it can also cause by this dotted line, which is hemorrhagic stroke, which dominates the CNS findings in about 20 to 30-year-olds. But there's another problem called those silent cerebral infarcts, and that's those little Litzel-like dots. If you look in the frontal lobe on the right, there's a bright spot that's about 3 millimeters, and there's another one on the left that is about 3 millimeters, and those little dots are little scars on the brain from silent cerebral infarcts. And the story that goes along with that is the story of this 8-year-old who's forgetting. And that's the only thing he does. He does not have paralysis. He does not have any other CNS manifestation. He may have an IQ that's about 7% less on average, or about 7 points less on average than his SIBS, but he has associative learning disorders. Okay? And it looks like he has ADD. And that's the consequences of these silent cerebral infarcts. This is another example. We should be able to see them as shown by the arrow in both the sagittal and the coronal cuts. Okay, and that's another. And this is the data when we look at adolescents and young adults. At 1 year of age, 11% of kids with sickle cell disease have these. At about 5 years of age, 25%. At 14 years of age, about 33%. And if we look in 30-year-olds, 53%. Could it be that that's something that affects their performance? We shall see. The last thing I want to talk about is transition of sickle cell disease adolescents to adult care. This is a thorny and difficult issue for a number of reasons, but it's a very important thing that has to be done. First of all, the thing that demands it is the lower right-hand graph that shows that while in 1970 only about 60% of the patients were reaching their 20th birthday, now 95, if you take all comers together, probably about 93 to 95% are reaching their 20th birthday, and they need adult care. They also need a future. They need a plan. People did not plan in the past. They just assumed they were going to die, or they were just going to sit home and not be able to work or do things like that. But now we need a plan, and built into that plan is the plan to help them transition to adult care. It's not unlike raising your own children and getting them to go to college or get gainfully employed somewhere around 19 years of age and out of high school. What is healthcare transition? It is a process of changing from a pediatric to an adult model of healthcare. The goal of the transition to optimize health and assist youth. And to achieve this goal requires an organized transition process to support the youth in acquiring independent healthcare skills and preparing for adult model of care and transferring to new providers without disruption in care. This is such an important thing that there is actually a nationally funded National Healthcare Transition Center. And if you don't believe me, you can go to www.transition.org and you will find it. And in fact, there you will find that they describe to you the process. Now, because of the limitations of time, I think at this point in time, I'm not going to go into great detail, but I'm going to say transition of young adults with sickle cell disease means you have to give them life skills to be able to live. How do you get a driver's license? How do you handle a checkbook, a banking account, read a bus schedule? You give them empowerment to take care of themselves, to understand their own medical history. You help them find a medical context both for the subspecialist as well as the family doctor. And so there are several barriers to this process. One is there's not enough hematology subspecialists who are adult caretakers. That matter, there are not enough primary care physicians who are expert or knowledgeable in the care of sickle cell disease. Funding. Medicaid funding, which Medicaid funds about 65% of our patients under 19 years of age. It is lost at 18 years of age. And certainly will be lost, less difficult to maintain under Obamacare, but will be very difficult to maintain under the present situation, or the new world. There's limited access to state-of-the-art care. 50% of the population in this state live in rural counties and are more than 60 miles from a major medical center that would have this kind of state-of-the-art care. And then there are intrinsic barriers to the patient, limited knowledge of healthcare systems and funding, limited self-help skills, and inconsistent technological connectedness. This is an important issue in adolescents and young adults, and so is sickle cell disease, and we have to add to our newborn screening excellent care and care in transition into the future. Thank you very much.
Thank you, Dr. Howard. We're going to go ahead and move forward. We have about 15 minutes left, and we're going to go ahead and pick up with Kiva Jones and let her tell us about the services and resources that are available through the Sickle Cell Association.
Thank you. And I think that was a great transition into what I'm going to speak about, particularly with the barriers that the sickle cell population faces. And I think we're getting close to me.
I didn't do a few slides yet.
The Sickle Cell Disease Association is one of 7 community-based organizations here in the state of Alabama, and our mission statement is to empower our clients and families with knowledge through quality, comprehensive programs and services. Basically, it's about educating the clients, educating the whole family. As you know, when someone has a chronic disease, it affects the whole family for a lifetime. And we think about there may be other children who are in that home and how they're affected by having a family member, a parent, or a sibling with a chronic illness. So education is key from the moment the children come into the world. At our office, these are a few of the programs that we offer. We have case management available. We have on staff a licensed social worker. And it's important to have that available because our social worker, she attends clinics. She attends the pediatric clinic. She also attends the adult clinic. So as we're talking about transition, she is one face that the children are able to see on both sides of their program. With that, she's able to talk with the family to see what resources are available in the community if there's an issue with getting transportation, which is one of our other programs that we offer. She's able to work with the families, particularly if they are coming from a rural area, to ensure that they're able to get reimbursement for travel. If there's some people in our local community who need transportation, we're able to get them where they need to go. If we are offering it through our van services, or if they need assistance with getting a bus pass, whatever they need, we're trying to make sure those resources are available for them. We also offer transportation to our after-school tutorial. This has been a program that is paramount to what we do for our children. Our case manager is able to identify through clinic those children who may have difficulty in school. We've been able to work with our local public school system in Mobile for probably a couple of decades now to provide after-school tutorial. We have our transportation services pick the children up from their schools. They come to our offices. We have contracted with tutorial program where we have certified teachers that all work in the Mobile County Public Schools who come in after school. They spend a couple of hours in there going over their homework assignments. We try and work with them and look at particularly what are those long-term projects they're working on, because one thing that we've seen is when children are away from school because they're being hospitalized, they need to have some type of consistency. And if they're losing some time in school, it can not only be a detriment to them educationally, but socially as well, because there's a stigma associated with being out of school and being ill, other children asking questions about what's going on with their health. So we try and make sure that we assist them to keep up with their grades. And we try and do that also through our summer enrichment program. We'll extend the education in the summer. We don't want them to get behind. Sometimes they have to have math packets that they're working on in the summer. We have those certified teachers coming back in, working with them on those math packets. It's also a time to give them other opportunities to see what else is available for them. Career development is very important. Dr. Howard mentioned now that we have people who are living longer, we need to give them those expectations that you've got to do well in school. You've got to start looking at a career path. So they're attending different businesses in the summer to find out what are the options for them. Newborn screening, trait counseling is imperative as well. We work with the Alabama Department of Public Health to provide the counseling to our clients who are born with sickle cell trait. Child and adult trait counseling, we find that parents who may have children with sickle cell trait may not have received notification It could have been because they moved and didn't receive that information. And we're also finding that adult trait counseling has increased, mainly because parents, when they find out their children have sickle cell trait, if they don't know their status, we offer on-site testing for our adult clients, and we'll have to educate them as well. We also are able to go to the local health departments. Our office covers 9 counties, and we're fortunate to go to the health departments in the 9 counties that we cover to provide services as well. We also are in the community, continue to educate through health fairs, visiting public schools. Sometimes we will do on-site testing at public schools. In-office testing is also available. And we also have a sickle cell educator counselor certification program. This program's been around as well for a couple of decades, and we're able to provide training to physicians, nurses, social workers, case managers, community health workers on becoming counselors specifically in the area of sickle cell disease and trait. Genetic counseling for hemoglobinopathies. We spend a lot of time counseling. In our service area of 9 counties alone, we'll receive approximately 400 to 450 children who are born with sickle cell trait per year. And that takes a lot of time trying to find those people to talk to them, but it's important because we need to know our status. Ultimately, we want people to know their status, to know what their options are. And in order to do that, we need to be able to provide concise, accurate counseling to those clients. And genetic counseling is just a process by which patients, clients, and or their relatives who are at risk of an inherited disorder are advised of the consequences and nature of the disorder, the probability of developing or transmitting it, and the options open to them in management and family planning. As a sickle cell counselor, you may be asked to counsel individuals with sickle cell disease or trait. There are various other trait hemoglobinopathies that we may counsel on. We see more counseling of the sickle cell trait, the C trait as well. And in the past year or so, we've seen an uptick in counseling for E trait and in D trait. In Alabama, there is a definition for a formal counseling session, and it is a face-to-face targeted session in which a counselor is providing information to a specific client whose individual sickle cell test results are known by the counselor. And this is through the Alabama Sickle Cell Oversight Regulatory Commission. In other states, telephone counseling is offered. Telephone notification of results is sometimes done by pediatricians' offices as well. And that's just a map of the service areas as it's divided up by the 7 community-based organizations. In a counseling session, the first thing you need to do is have an accurate diagnosis of sickle cell trait or sickle cell disease. When we talk to people, there are some things that we need to do in advance. Beforehand, we need to have everything in place. These are some steps, particularly looking at how long is a counseling session. Well, based on having counseling through the newborn screening program, the first thing that we have to do is reach out to those patients. We're sending them letters in the mail. We'll also do follow-up with phone calls if we don't hear from them. And when they come to our office, we can expect to spend maybe 15 to 30 minutes per client. And the one thing about having in-person counseling is that you can gauge the understanding that someone has on the information that you're providing. Preparing for the session, it's important to make sure you have the accurate information per client, knowing the gender of that person, knowing the race of the person as well, also knowing specifically what the diagnosis is listed that has been provided by the newborn screening program through the Alabama Department of Public Health. In your greeting, it's so important to let them know who you are and your relationship, because sometimes people will come in and they're worried. They've received a letter from us stating that we have their results from their newborn screening, and they don't understand how we receive those results. So during your greeting, it's really good to explain to those parents that you work with the Alabama Department of Public Health to provide these results, and explain to them as well, had this been an emergency, you would have received it from your doctor. So, and that calms people down before you start talking about having trait. And we will provide those results. And it's important to get a family assessment, because sometimes you may get a deer in the headlights look from a mom. Or you may have a mom who will say, well, I pretty much thought that's what you wanted because I carry the trait. Sometimes mothers don't know if they carry the trait. They don't know anyone in their family who either has sickle cell disease or trait. So getting that assessment will help you to gauge how long it's going to take you to counsel. It's important for us to clarify the difference between sickle cell trait and sickle cell disease. So in the counseling session, you're able to give them an overview of what is sickle cell disease, and from there you can talk about sickle cell trait and explaining the patterns of inheritance. That's important as well, because parents want to know, how did I get this? How did my child get this? And we're explaining to them, and we're having visual aids. That's very important to have, because you're able to map it out and show them the occurrence of if one parent carries the trait and if another parent does not carry the trait, what's the likelihood of passing on trait to your children. And when they're able to see that, it helps them understand it as well. We also spend some time talking about the rare complications that are associated with sickle cell trait, and we don't want to scare parents, but with new mothers, it's important for them to understand that there may be some rare complications, but we do stress that they are rare. And it's very nice if you do have a parent who already knows that they have the trait, and one of the things you can talk to them about is whether they've ever had any complications, and now as an adult they realize, well, I've lived my whole life carrying that trait, and it is able to calm their nerves, and they feel more comfortable with the diagnosis. Concluding the session, you can go through all of these steps, but if the parents leave that meeting not understanding anything that you've talked about, you haven't done your job. Allow them to ask the questions, and if there's something that you don't know, quickly tell them that you don't know. We're fortunate to have a pediatric clinic here in Mobile where we can talk with Dr. Wilson if we don't understand, if there's some other questions that we can't answer. If there are instances where parents feel that they aren't empowered to ask those questions to us, we will refer them to websites where they can get more information as well. But it's ultimately, we want to make sure they understand their diagnosis. The Sickle Cell Educator Counselor Certification Program also provides an avenue for us to train professionals. We've been fortunate to work with the University of South Alabama and the hematologist on site there. They will come and teach these courses for us. And our goals are to provide training and education and counseling for individuals diagnosed with sickle cell disease, trait, and other related hemoglobinopathies. We offer the education about these disorders to those healthcare professionals, paraprofessionals, community-based workers as well. We see a lot of social workers who are working directly with parents who children have sickle cell disease and are working with adults with sickle cell disease. The requirements: you must attend all sessions for the four-day program. You're conducting an educational presentation on any aspect of sickle cell disease and any other abnormal hemoglobin. And you must successfully conduct an actual counseling session under the supervision of program staff. You're required to pass the test with 80% or higher, and we do offer a retest within the first 3 months. Otherwise, you will have to take the class again. As you can see, it is extensive. It's very intense as well, and it gives you an opportunity to really understand the complexities associated with sickle cell disease and sickle cell trait. One of the things that we find is that if a physician is not regularly seeing patients with sickle cell disease, it can be very difficult just through the newborn screening process to even talk about sickle cell trait, and explain to a parent what does it mean to have sickle cell trait. So we encourage physicians to not only reach out to the sickle cell community-based organizations in their area. We encourage them to send nurses to training, anyone that may be need to directly work with our clients. We'll do whatever we can to assist you, but one of the things we want you to know is that our clients are definitely looking for this assistance. Sometimes they just don't know what to ask. And if they're in the doctor's office, and if you don't know, get to know the community-based organization in your area, because it will make your life a lot easier when dealing with sickle cell disease, sickle cell trait, and new moms. Thank you.
All right. Well, thank you all for presenting, and I'm under the impression we don't have any questions. So it is 3 o'clock. We will conclude. Again, thank you, Dr. Wilson, Dr. Howard, and Kiva for coming today and sharing your expertise with us. Just a reminder for those of you watching, if you would like to receive CE credit for this, please go to the website, fill out the appropriate forms for your CEUs, your CMEs, and thank you for joining us today.